This is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and our presentation will be by Dr. Daniel Hofer, a family physician, who is Chief Medical Officer for Outpatient Palliative Medicine for Sharp Healthcare and Medical Director for Sharp Hospice Care in San Diego. Dr. Hofer, it's all yours.
Thank you, Larry. So for this discussion, we're going to be talking about geriatric frailty. This is a particularly important geriatric syndrome. I want to ask you to think about understanding geriatric syndromes in the context of the care that you provide to your patients, because everything we do with syndromes now is this balance between fixing the organ system but accelerating the geriatric syndrome. And so that's the new equation in healthcare, is how do we fix a medical problem without making the geriatric syndrome worse? But of course, we first have to understand what these geriatric syndromes are. And today we'll be talking about frailty. Now, I've been in healthcare since 1986. And when doing histories, I would hear this all the time. My father died of old age, or my mother died of just getting older, she gave up. And in fact, people don't die of age or giving up. Imagine putting that on a death certificate. You know, my dad was old, or putting a number, 92, or she just gave up. None of that works. Something is happening. And when you ask that question, something is happening, I had to go personally back and figure out, well, what is it? Because the more we understand this, the better we can do in managing our patients and give them better quality until that very last breath of their life. Sorry about that, had a little slow response. So these are my disclosures. They will not interfere with this presentation. We will be talking about geriatric frailty, and we're talking about the importance of this syndrome, and we'll be talking about treatments and what you can do to slow the progression of frailty. So what is frailty? Frailty, and this is the classic definition, is a physiologic syndrome characterized by decreased reserve and diminished resistance to stressors resulting from cumulative decline across multiple physiologic systems and causing vulnerability to adverse outcomes. So what does all that gobbledygook mean? It means that these patients have lost their stem cell mediated repair. They do not have any reserve. This is that car that's had 400,000 miles on it. It's still running, but God forbid if something goes out, the whole car is a goner. It's over. It's not because one thing's not working, you could just replace it. It's because the whole car needs to be replaced. And unfortunately, in the human body, we can't do that. It's important to recognize frailty is the lack of physiologic reserve. And that's critically important in understanding why many of the frailty models are not truly frailty models. It's also important to understand that frailty is progressive, which means you can intervene, and the least that you can do to slow the progression, if you're working to slow the progression, is to understand the frailty process, but also you can talk to the patient or their family about what's actually going on so they're morally resolved in their decision-making and understanding. And it is, in fact, independent of other medical diseases. It is its own diagnosis. That's also important in looking at the models people might use to define frailty. It's an expensive disease. Pre-frail patients, maybe one or two of the characteristics of frailty are more expensive than non-frail patients. Mildly frail patients, maybe with 3 of 5 symptoms, more expensive than fully frail patients, will cost per year significantly more than age-matched control patients. What about this concept of physiologic function in excess? Well, it takes a while for most organ systems to lose their physiologic reserve before we have any evidence of failure. So cardiac and pulmonary issues, that's very significant. We don't see hematologic changes or feel hematologic changes until a significant loss of reserve. Hepatic function, renal function. Renal function is actually the easiest one to look at. I tell my patients all the time, you know, your kidneys are getting worse every year, and you can see this on your electronic health record over the last 20 years. Your GFR was, 75, and now it's 55, and that was 20 years ago. You didn't feel any of that, did you? But slowly, as you get older, things are slowing down and getting worse. You still have plenty of renal function before you feel anything, but that process is going on. Same thing with blood sugar, sensory capacity, cognition. All sorts of things are going on that are slowly using up our physiologic reserve. So why do we fail to recognize frailty? Well, number one, it's not an organ system model. It's a syndrome, so it doesn't fit the classic disease model. It's a gradual decline that may not be appreciated in strength, function, and nutrition. It may be mistaken for old age, but again, old age has something to explain it. And we may not, unfortunately, evaluate that a clinical response is relevant. You can do something for people that have frailty, such as could have been done with my father had his providers noted that in that left picture from the previous presentation that my father was frail at that time. So unfortunately, frailty is not identified until late in the process, and where there may not be anything you can do to delay or prevent inevitable outcomes. And of course, some of those inevitable outcomes are that we're sending patients to the hospital or for procedures that might actually make their frailty syndrome worse. So knowing what you're getting into and identifying frailty early is critically important in managing these patients. This is the classic criteria adopted by the American Geriatric Society. This is the Fried-Hopkins frailty phenotype. There's also a frailty index, but this is the one I would encourage most people to use because this, in fact, defines the physiology of frailty. The other models, to some extent or in their entirety, do not directly reflect the physiology of frailty. And that, in fact, turns out to be particularly important when you're having ethical and medical discussions about care. What are those criteria? Loss of strength. So people should be in the bottom 20% of strength categories. If you do standardized testing with a dynamometer, they should have 10% or 10 pounds. Some people say 5 pounds of weight loss in the last year. Really depends on how big the patient is. Decreased activity level. Many of these people will have increased sleep and that as a consequence, poor endurance. So if they do go out, they're easily fatigued, they just are intolerant to activity, and they have slowed performance. So a prolonged time up and go test, they may develop an unsteady gait. But these are the people that we see over time that are developing many of these characteristics. And once you have enough, that's called frailty syndrome. It's the phenotypic representation of the underlying physiology that's expressing itself in how you see the patient. There are over 60 models of frailty. However, most don't reflect the frailty process. Most of these are actually multimorbidity or comorbidity models. You know, ISAR, it would be an example of that, identifying seniors at risk, or MI5, MFI5, MFI11, Modified Frailty Index. Those are actually multimorbidity models, and they don't specifically represent frailty. Now, it's not that they don't prognosticate for something, it's just that they are not representing the physiology of frailty. And then there's disability, which is also a separate category that gets misinterpreted as frailty. So this is what we're actually referring to when we look at comorbidity models, MI5, MI11, ISAR, disability, a different model, and frailty, and they do overlap, but frailty is its own independent diagnosis and should not be confused. And I can't overemphasize the importance that frailty is not the same as disability. I showed in the last presentation, Terry Shivo. She has 3 of the 5 characteristics of frailty, but she's not frail. Why? Because all of her organ systems have physiologic reserve except for her cognition. And so you can't use that as an explanation to call her frail. She will tolerate insults for quite some time. And when I would accept patients into our subacute ventilator unit, you had to determine whether this patient was frail prior to coming there and have a different standard of discussions and orders, medical ethics and medical management, than you would for somebody who was frail. Secondary features of frailty is decreased cognition, balance, motor processing. They'll have a change in emotional status, poor self-rated health. They may be deficient in social support, which makes it particularly difficult to manage these patients. It's a complex physiologic process, and it involves the anorexia of aging, which is regulated by neuroendocrine changes. You will have disease processes that contribute to the senescence of aging and the sarcopenia that we see. And all of this is altering the physiology, the inflammatory cytokines, making people disabled, dependent, and many of these patients, in fact, will become frail. Frailty has been associated with acute illnesses, falls, worse or new functional impairment, institutionalization, lengths of stay. These patients have more prescriptions, and that's unfortunate because most of them should have less prescriptions, hospitalizations, higher mortality. I love, in fact, one of my geriatric colleagues stated this, that frailty imparts an exponentially increased vulnerability to death and disease, so exponentially increased risk of morbidity and mortality. When you look at frail patients in the context of the needs of the terminal demographic or the pre-terminal demographic, these are the patients who aren't driving, but not only they aren't driving, they're having a difficult time walking across the room. So when they show up in our offices, we may not appreciate the significance of the functional decline and the frail aspect of their life. They also tend to have financial restriction because they've burned through all their finances, many of them, and that makes it particularly difficult for them to be compliant with our care. They can lack social support, family support. This can also lead to compliance deficit, and some of them will have cognitive deficits. And all of these things make it harder to manage these patients without them ending up in the hospital or being institutionalized. There's different types of frailty. Primary frailty will occur in the absence of any significant overt disease. In fact, if you have a frailty model that mandates overt disease, that is not a frailty model. Again, that is a multimorbidity or a disability model. Frailty models can exist in and of themselves. Secondary frailty is frailty which occurs with associated known advanced disease. So somebody who has COPD or heart failure and has secondary frailty features should be called COPD with secondary frailty or heart disease with secondary frailty. We used to use the term cardiac cachexia, for example. That's better labeled advanced cardiac disease with secondary frailty. Why is secondary frailty important? Because the 4-year prognosis for these patients is extremely poor, 600% increased risk in mortality and 1,000% increase in risk in morbidity. These patients, if you send them for a procedure or hospitalization, are going to do markedly worse in both morbidity and mortality. So what's going on from a cellular perspective in patients with frailty? And the fact is that we are all born with a finite capacity for stem cell mediated repair after chronic exposure to tissue injury. And that's the tissue injury we've been having since the beginning of life, just the normal metabolism. 75% of this is not in our control. It's just the normal mitochondrial metabolism that goes on in our cells throughout our body and throughout our lifespan. Once that capacity is exhausted, a cycle of pathologic inflammation ensues that leads to overt disease manifestations. Now, it's estimated we have anywhere between about 20 and 90, depends on who you talk to, stem cell cycles. It doesn't matter, but once you burn through those cycles, you have to work on whatever residual, what reserve you have. And when that reserve takes a hit, you don't get it back. You can't repair what is not able to be repaired because you've lost your stem cell mediated repair mechanism, and that inflammation grows over time mediated by pro-inflammatory cytokines, and it integrates into a disease process that at the end of life can manifest in many ways. The prevalence of frailty is incredibly common. People don't realize that our younger patients are frail. 1 out of 14 to 1 out of 4 people over the age of 65 are frail. That's quite a few. So if you have a senior population, you should be seeing these patients regularly in your office if you take care of anybody over the age of 65. If it's over 85, it's 1 out of 3 to almost 1 out of 2 patients. And these numbers were validated in the Cardiovascular Health Initiative and the Women's Health and Aging Studies 1 and 2. What's the pathophysiology of the syndrome? Well, it's a loss of skeletal muscle. It's that term we used before. It's sarcopenia. Sarcopenia means you're going to lose your anti-inflammatory cytokines. Starting at the age of 30, you lose about a half a pound of muscle per year. That accelerates at 50 and then again around 70, 75. It may also be manifest in visceral protein albumin loss. You can monitor albumin as a surrogate marker for lean body mass. And we know in studies for even people with normal albumins, the lower the albumin, the worse the outcome. You can look at neuroendocrine dysregulation. We do not know if any of these can be supplemented yet. Testosterone, DHEA, cortisol, human growth hormone, they've all been tried. No evidence that they improve outcomes at this point. And then it's this process of chronic inflammation, these pro and anti-inflammatory cytokines. You know, the inflammatory markers we use, C-reactive protein, SED rate, highly sensitive CRP, those are all surrogate markers to the underlying process, which is this balance of pro and anti-inflammatory cytokines. So frailty has been associated subsequently with decreased muscle function. That's not surprising. Neurologic function, that's the inflammatory component of frailty. Decreased energy metabolism. This is why when you stick a feeding tube in an advanced elderly patient, it doesn't help. And the reason isn't because they're not getting enough nutrition over hand feeding. It's because the machinery to metabolize that nutrition appears to be turning off. So when you stick a feeding tube in, those patients have more pneumonias, more pressure ulcers. They don't improve the biochemical markers of malnutrition. And in fact, it can actually be associated with higher mortality. They have altered immunity. It's called immune senescence, which is why you should vaccinate the people around them, perhaps more than the patient themselves. They have altered hematopoietic and endocrine function. In fact, it may be the process that defines anemia of chronic disease. From a chemical cellular level, this is that balance of pro and anti-inflammatory cytokines. Pro-inflammatory cytokines are coming from your adipose tissue. In fact, the Mayo Clinic calls these adipokines, and that many have been identified. I've shown you a few: IL-6, IL-2B, tumor necrosis factors. There's quite a few of them that are out there. Tumor necrosis factor has been renamed as cachexin because many people say, well, I don't have a tumor. Yes, you don't, but it's still called tumor necrosis factor, so we renamed it to cachexin. And then there's anti-inflammatory cytokines such as IL-10. It's another hormonal process that appears to be this balance of pro and anti-inflammatory cytokines. What do these pro-inflammatory cytokines do? And you can see the issues that make it worse: aging, inflammatory disease, maybe antioxidants, non-steroidals, corticosteroids make it better. But what these pro-inflammatories do is they cause the diseases that we see in the elderly: the sarcopenia, the cachexia, the bone disease, the blood disorders, the Alzheimer's, the atherosclerosis. Every time you hear somebody say, well, it turns out this is an inflammatory process, and this is what they're talking about, this pro-inflammatory mediated cytokine process. And it's the same thing for cognition. And this is why when a person gets a UTI and they're older, that cytokine mediated process affects cognition by causing inflammatory changes in the brain. And it's also why you see these negative outcomes in cognition and other outcomes for people who are being hospitalized for surgeries or for just general hospitalizations. So one of the things you realize in the importance of understanding frailty is that when you lay a patient down who is older, they lose 5% of their muscle strength per day. It accelerates the sarcopenic event. Now that compares to you and I, which we lose about 1 to 1.5% of our muscle strength per day when we're in bed bound in the hospital. And that is one of the reasons, one of the many reasons why it can be so much more dangerous to put an advanced elderly patient in bed permanently or in bed in the hospital instead of having them be treated at home or in their place of residence. In their place of residence, they tend to get up and move around more, be more mobile and active. Frankly, in no place should they be restricted to bed care only if at all possible, because that is almost certain to guarantee an advancement in their geriatric syndrome. So why are we addressing frailty and all of these issues? It's because we can have better outcomes. We'll have less falls, we'll have more autonomy, they'll have better quality of life, they may have more energy, they may maintain their cognition, and frankly, we have better patient and family satisfaction just because they feel like we're doing something. But most important, if not the most important thing about the progression of geriatric syndromes and frailty is that we are preparing the families and the patient for the inevitable outcomes of the progression of disease. We know this is happening, just like bone density or just like COPD or renal function. We know things are progressing over time, so we can guide them in the inevitable consequences of the natural progression of disease and the lifespan. Frailty has been one of the metrics for which we are supposed to evaluate our patients, and this has now been going on since 2012. So 9 years later, we are still behind on doing frailty evaluations on every single patient as requested by the National Surgical Quality Improvement Program over the age of 70. That is the age of 70. Every single patient should have a frailty evaluation just for the reasons that we talked about, because you can't fix the organ system without accelerating the geriatric syndrome, in this case frailty, and that puts the patient at risk, and you can make better decisions about what you would do or if you would even have the procedure if you understood whether a patient had frailty or not. This is an index evaluation of frailty. This is Thomas Robinson. I'm just going to show you how this worked for this particular research article. These were 65 years of age and older. The average age was 73. They were going for major operations expected to need the ICU. They looked at frailty characteristics associated with institutional discharge, something that many patients do not want to be a part of. And if they do want to proceed with the procedure, at least you can prepare for that inevitability. They did timed up and go tests, which is something we should all be doing on our patients prior to sending them for surgery at this age, not younger and healthier ages, but for the elderly population. Any functional dependence, older age, they looked at the Charlson Comorbidity Index, the hematocrit albumin, and they did a mini-COG. And the two issues that were most at risk of a patient being institutionalized were functional issues and timed up and go test. Now you can look at the other evaluation tools as well, but these are index markers of frailty. But you can see why as well, these are not specific to frail patients, which is why it's not my favorite tool to use. The phenotype is the physiologic expression. You can have other people with other organ system diseases, liver disease or renal disease, that might have these issues, but that does not make them frail. That means they have organ tissue injury. This is an even better research article done by Martin McCary. He's a surgeon from Harvard and also has a Master of Public Health. For patients with frailty, he went for major procedures. They'll be in the hospital twice as long. Now think about that. Frail patients are in the hospital twice as long, losing 5% of their muscle strength per day. Those patients will lose 40% of their muscle strength in that hospitalization. It is not true, and you'll see that in upcoming medical research, that these patients go back to their previous level of function. Surgical complications will be almost half the patients, twice as many complications as non-frail patients. Even for minor procedures, about 70% will go to institutions. For major procedures, 14 times as many. 14 times as many will end up in an institution. It goes from 2.9% to 42.1%. So what about the treatment of frailty? Well, this was a great research article. It just came out from the American Family Physician magazine, and looks at the Fried frailty phenotype. I'm so happy they chose the Fried phenotype to look at frailty. And you can look at how to evaluate the frailty phenotype more specifically and using specific metrics. You would want to evaluate weakness. Age-appropriate exercise is always important. I don't care what age the person is. I had a patient whose sole goal was to be able to continue to bake pies, and so I had her doing biceps exercises with soup cans so that she could lift her arms up to put the pie into the oven, which was what she was having a problem with. Lower extremity resistance training. People forget about that. And they don't have to go to the gym and do leg presses. They can do squats or other exercises. You can do rubber band stretches where you push your leg out. This will double their leg strength. It will increase their walking speed, which has been associated with markedly improved outcomes as patients need interventions, and spontaneous movement, which is also associated with improved outcomes. There's a list of strengthening exercises you can do. I did use this table and gave credit to the American Families of Physicians because it's such a easy table to read. And you can hand this to your patients and say, why don't you try doing these things? And they're easy to do, and they can do all of these things at home. We know that physical inactivity, unfortunately, is the strongest correlate of body composition, which is why we should be encouraging patients to exercise no matter what their age is, because that will prevent the progression or even the development of frailty. And in fact, we know that people who were exercising by 200 kilocalories per day versus 200 kilocalories per week, now regular exercise above their normal activity, the ones that were doing 200 kilocalories per day did markedly better and had inverse correlation with mortality. People should be working on balance. Tai Chi and other balance programs have been shown to be beneficial. We have balance programs in our physical therapy department. I think you can do those at most fitness centers now for seniors as well. And we know that 1/3 of people over the age of 65 fall per year, and 10% of those falls end up with significant consequences. For African Americans, it's head trauma, and for Asians and Caucasians, it's usually hip fractures. None of those are good. So what we should be doing is to keep people from falling in the first place, and we shouldn't be screening for falls. I think that was actually a mistake. We should be screening to be sure people were sent for fall prevention, and fall prevention interventions have occurred because we don't want to even wait for that first fall. And here's another tool, frailty balance training prescription, exercises you can do. One of the things you can see where patients are starting from is to do a tandem foot test, that have people put their feet together side by side, stand for 10 seconds, then heel inside the arch of one foot, and then the toe and heel, and stand. All of these you stand for 10 seconds, and then you can see if you can stand on one foot with the other foot on your calf, which I cannot personally do, but many people can. Those people actually have excellent balance and probably don't need these interventions. What can you do about to help people from falling as well? Well, you need to be sure that they are not on medicines that would interfere with their ability to balance. So anything that lowers their blood pressure too low, any medicines that make them dizzy or weak or orthostatic. Make sure that they have visual equipment, so the proper glasses, take care of cataracts if they're a problem. They should have proper footwear. Some people would suggest we should be supplementing them with vitamin D, and that should have been going on for quite some time. I mean, in any case, there's lots of things that you can do, and if you look down in that right box, those are the things you can do to help these folks. Well, what about sarcopenia as a part of the wasting process and muscle issues that prevent some of these people from exercising? Well, some of this you can't do anything about, but interestingly, there's other things you can. Genetics we probably can't affect, but cytokine levels are probably more treatable than we realize. There's a lot of literature coming out about antioxidant diets and healthy eating. Just eating too much itself creates cytokines. We can't truly affect the hormone production. We don't really know which ones to deal with anyways. The oxygen-free radicals are a part of mitochondrial metabolism. So again, that's a dietary issue. We want to make sure that the nutrition people do get is good nutrition. We want to help them with their cognition and avoiding cognitive decline. There are actually things you can do for that, and that we'll be talking about that when we talk about delirium. And we want to be encouraging mobility and exercise in every single patient. Not some patients, every patient. Mobility and exercise, whatever they can do, is important. I always tell my patients too, because they come in and they start with a list of why they can't do, my gym closed or it's rainy outside. And I say, okay, stop. Tell me what you can do. I want you to name 3 things that you can do, because usually there is something they can do. And we come to a conclusion, well, yeah, you can, get a home exercise bike, or you can just, lift books, or you can lift, soup cans, or you can do squats and do this for 30 minutes. You can get a Zumba video. All these things are available to these patients, and some of them do actually follow through if you show them how easy it is to exercise at home. It doesn't have to be the sophisticated exercising that is always being marketed on TV. So sarcopenia is a complex problem, but there are things we can do to slow that process. And the sooner you start exercising, the better off you will be, and all of our patients will be in their life. One of the problems we also see in the elderly is a part of the inflammatory process. In fact, a lot of people mistake the dyspnea on exertion or the fatigue with exertion. They're always looking for heart failure or COPD, but I've seen plenty of patients now that have no explanation aside from frailty. So I would encourage people to include that in their differential when an elderly patient comes in and says, well, when I exert myself, I just get exhausted. That may be a component of the frailty syndrome, and don't blame it on their COPD if their pulmonary function tests are good enough or their heart failure ejection fraction is good enough. That is probably being mediated by their frailty syndrome. And you can change their environment, you can adjust temperatures, and if you ever go into a nursing home in the middle of summer, you'll be stunned by how many patients are wearing sweaters in the middle of sweltering heat. But that's what makes them comfortable. So go ahead and reorder, change the temperature, change tasks. You could read these other ones. I encourage, and I will say this in very many times in almost all of my presentations, please eliminate medicines that are ineffective or inappropriate, that are usually based on younger and healthier patients and the elderly demographic. So if you can eliminate beta blockers, antihistamines, tricyclics, anticholinergic medications, there's actually a long list of medications. And for some patients, you can actually try a trial of methylphenidate. For those of you who have tried this, and I have, it's a miracle drug for those that it works for, but we tend to forget to use it, and we use it too late. So if you use it earlier for people that are exhausted, they actually can do very well. So please learn to demedicate the elderly according to clinical guidelines. It is very beneficial to our patients, and I'm going to show you some literature that shows that the polypharmacy of over-medicating our patients is actually associated with higher morbidity and mortality. What about the issue of weight loss? You know, I used to work as an expert witness defending physicians and institutions, and patients were suing because their loved ones were suffering, they were losing weight, the patient died, and the problem isn't that the doctors got it wrong, but they didn't explain or have the professional skills to explain what was actually going on. And I want to show you these studies about weight loss in that regard. So this was published in JAMA, 34 trials, 2,500 participants, showing that supplements containing protein and calories had little or no effect on weight gain, with no effect on strength or function. So all the supplements in the world didn't help these patients do better. This was a Cochrane review, almost 10,000 patients, a little bit more than 10,000 patients, 62 trials. The mean difference was about 2.2% in weight for 42 of the trials. However, there was no significant reduction in mortality in the supplemented versus controlled groups for malnourished patients. Once the patient gets to that point where they're malnourished, you're not going to reverse that by putting in a feeding tube or giving them more nutrition. What was significant was that if you recognized what was going on early in undernourished patients, you may be able to have a benefit. But most patients were undernourished before they came to me in the nursing home or they came to our patients in the outpatient arena. And that would have been the responsibility of the family member or the patient to recognize that was that time to increase their nutrition. I want to show you one more study. This is an older study, very powerful. Didn't understand frailty at the time that this article was published. Not just that I didn't understand it, but the healthcare industry didn't understand it. It's from Cynthia Henderson. And she worked in a nursing home back in Boston, one of the high-end research nursing homes. 500 patients with feeding tubes were followed over a 5-year window, and about a third of them started to lose weight, even though they were receiving exactly the same nutrition and care that they were in the years preceding. And what was the conclusion to this study? And the conclusion was that adequate calories and protein were provided with sample means exceeding standard means for energy, protein, and micronutrients, meaning they were getting a little bit more than would have been calculated by the dietitian was necessary to achieve homeostasis. Still, subjects showed weight loss and severe depletion of lean and fat body mass. This study shows that despite administration of apparently adequate formula, micronutrient deficiencies and marasmic malnutrition exist in chronically ill patients. And it looked as though if you took all of these patients over time, they're all going to eventually start to lose weight. When they looked at these patients on necropsy, they did not have cancer, they did not have other problems, they just started to lose weight. And what would mediate that turning off of the ability to metabolize nutrition? The elevation of pro and anti-inflammatory cytokines. It's the pro-inflammatory cytokines. And we've been able to replicate the exact phenomenon in animal studies by infusing pro-inflammatory cytokines. What was interesting for these patients too is that when they started to lose weight, even though they were following precise clinical guidelines at that time, about 2/3 of these patients developed pressure ulcers. So that's not a surprising event. That is an inevitable event for most patients because the underlying physiology is changing. There's nothing you can do to stop that. So the conclusion to all of this research is there's limited effect to supplemental nutrition on outcomes because the underlying cause of weight loss in frail patients is due to low-grade inflammation and neuroendocrine dysregulation. These patients are not starving and they are receiving adequate nutritional intake. They're not receiving diminished nutritional intake or inadequate nutritional intake. So I always forewarn my patients, which is why we have to be talking about this much further upstream with them, is that if you get to the very end of life and you are existing with frailty, the end of life can be very ugly, unfortunately. Or you just have to deal with the physiologic changes and accept life for what it is. You will start to waste away, develop cachexia, sarcopenia. You will have confusion and delirium. These are inevitable. You will have more infections and you'll have more pressure ulcers. That is the end of life process. If you want to engage in decisions prior to these events, you need to do it sooner and fill out the pulse properly and advance directives and have discussions with your family and your physicians so that your end of life experience can be wonderful instead of a series of unfortunate events for which you were unprepared. I actually gave this phenomenon a name. This is my word, so it's a new word. I call it mortipause. I called it that because I didn't have a term to use. Nobody had made one up. So I call it mortipause when a patient enters that time of their life where we're starting to see the accelerated decline in their physiology, where there's really no way to reverse this. They're losing weight, they're developing all of those syndromes. But what can you do if you caught these patients earlier? There's lots of things you can do to slow the process with their weight loss, provide foods of choice. It always used to be, intrigued by the fact that patients would come to the nursing home, 1800 ADA, low salt, low fat diets. And what would happen with those patients? Many of them would die. They hated the food, they couldn't taste, they didn't do well. But when we told them you can eat whatever you want, they brought in salty, spicy foods of their ethnicity or of their choice. They actually did better. We worked around the exacerbation of their medical conditions to keep them comfortable, but they ate what they want. They actually did better. You can provide alcohol in moderation. They can eat smaller meals. Oral care is particularly important. Dentition is important. When you can, you should give nutritious food. That's, of course, important. Supplements might be helpful. Treating pain and depression, very important. And when you need to get rid of medications, once again, where's that word? Anticholinergic medicines make it difficult to swallow, or dysgeusia medicines that cause altered taste. And patients like to eat in groups. That does help patients to enjoy their food more. It's something to think about. What about Megase? There's in fact no FDA-approved drug to address weight loss. We do use Megase, and there may be some clinical evidence for cancer patients or some post-surgical, but for the general patient, Megase has not been shown to improve outcomes. In fact, all it does is increase the risk of thromboemboli, hypocortisolism, and diarrhea. Mirtazapine, the American Geriatric Society says only use mirtazapine as an antidepressant when you also want to increase their appetite. SSRIs may also be beneficial in improving weight. This is that time where weight change in SSRIs is appreciated when it's weight gain. But what about the rest of us, just to show you the issue? And you hear about this with all of these fasting diets or calorie-restricted diets. And this is not new. I was back at UCLA when they were doing these studies on animal studies, and virtually every mammalian species they studied showed that when you withheld food one day and fed them the other day, or significantly reduced the calories in their diet, these patients lived longer. In fact, the researchers were doing that to themselves, where they were eating one day and not the next, and they were actually doing better. And in fact, in my own life, I've adopted not eating lunch. So I eat a small breakfast, I go for 10 to 12 hours, and I have a nice dinner. And I can only tell you, I wish I'd done that 20 years ago, because I feel fantastic by not eating lunch. It doesn't slow me down. My patients are shocked how much energy I have at 3, 4, and 5 o'clock, and it really keeps me going. But in this particular study, calorie restriction was proven to be the most effective method for extending both median and maximal life expectancy in several mammalian species. This is that oxidative process that's going on intrinsically in our body, causing physiologic damage to our organ tissues. So it's that oxidative process that we're trying to affect. This decreased fat stores, which means we decrease interleukin-6. Calorie restriction decreases the rate for which proteins are oxidized, superoxides, hydroxyl peroxide, peroxycholic acid. Calorie restriction is believed to counteract the stress-associated oxidative damage. And so what does that mean? That means this is the life cycle. Your mitochondria produce oxidants. Your oxidants damage your proteins. Your stem cells repair your damaged proteins. That is on top of any trauma damage you get from a abuse of alcohol, a motor vehicle accident, an infection, or a genetic disease that you develop. And once you run out of stem cells to repair your organ systems, you go into low-grade inflammation, and eventually, if you are lucky, you develop frailty, because that appears to be the way you use up everything that your body has to give. You'll see micronutrient deficiencies with frailty. So any 3 micronutrient deficiencies have been associated with frailty. These are easy ones to measure. Here's an office prescription for frailty to think about, does my patient have frailty and what am I going to do about it? So we should be treating depression so that they'll do better. You can think about endocrine issues, but we have nothing to do about that yet, but something to think about for the future. We might be finding some ability to affect frailty. Nutritional intake does matter. Resistance training, of course you want to protect their heart because you don't want them to do well and then have a cardiovascular event. Prevent isolation because that can affect frailty and lifestyle habits. Limit pain, balance exercise, and annual medication review. So what about the prognosis with frailty? We'll review this very quickly. Anybody with frailty, you can tell them they're 300 to 500% more likely to have higher mortality with any event or any outcome. The trigger event for frailty in somebody who is hospitalized will have an acute phase response. If you're on the left side, you recover, your cytokines go back to normal, you improve, and you're discharged. If you have underlying frailty, as we see, for example, in advanced dementia patients, you'll have acute on chronic inflammatory changes. You'll have significantly elevated cytokine levels. These will suppress the energy balance of cholesterol, hemoglobin, and albumin. Many of these patients will get worse and die in the hospital. That's why mortality rates are so much higher with frail patients. Others will circle around for a while, and then they will ultimately die sooner than age-matched cohorts that did not have frailty. And this, in fact, is why the mortality rate for the advanced dementia population is 53% and 55% respectively for hip fractures and pneumonias in the demented population. You can look at other biomarkers. Cardiovascular health study looking at hemoglobin, regardless of whether the hemoglobin was elevated or low. The hazards ratio for mortality was 1.57, independent of cause. You can look at inflammatory markers in frailty. IL-6, but we don't usually measure that in our lab, so we use surrogate markers. CRP, it's 1.6. If you look at IL-6 and CRP with respect to albumin, diminished albumins of any level, frankly, it's just a straight line down. The higher the albumin, the better you are. The lower the albumin, the worse you are. Increased morbidity and mortality. I wanted to show you this particular study because this was done in the state of Ohio. 15,000 patients. They followed all hospitalizations and they looked at their albumin level. 21% of the population had hospital admission albumin of 3.4 or less. For those patients, they were 350% more likely to die in the hospital just by looking at one single biomarker, and they were in the hospital longer. They're also more likely to be readmitted. What happens to albumin as we age? We lose about 10% of our albumin per decade. So it's anticipated that your albumin will drop and put you at higher risk. You can look at that in this regard. That's mortality on the left, that's length of stay and readmission on the right, and you can look at people as they get older and look at their albumin level as they drop. In fact, it may be better to be an 85-year-old with an albumin of 4.0 than it is to be a 40-year-old with an albumin or let's say a 50-year-old with an albumin of 3.2 if you want to survive during a hospitalization, because the albumin is such an important player in outcomes. This was a research article I used to use in the nursing home, single biomarker, simple to use. I would get albumins repeatedly and routinely in the best compensated state. These patients that had low albumins had a 50% mortality rate at 1 year. Just again, a reflection of that inflammatory process. I want to quickly talk about cholesterol because people don't use this very often, but there's other markers you can use. For cholesterol for patients in nursing homes, again, this is cytokine-mediated suppression of cholesterol production. There is a J-shaped relationship between mortality and serum cholesterol. This was controlled for age, blood pressure, weight, history of MI, creatinine clearance. You can see all the things it was controlled for. You can see the exclusionary criteria. But what I want you to see on the bottom is this. The nadir of mortality for patients in the nursing home is a total cholesterol in this particular study of 270 milligrams per deciliter. Now think of that in the context of where we're trying to push cholesterols now. And think of that in the context of the fact that we deliberately excluded these people from research. If you get down to cholesterols of 155, they were 520% greater risk of mortality than patients with 270 milligrams per deciliter. Different study, this is men. The cholesterol level is less than 150. Death rate was 63% at 14 months versus 63% versus 9% if it was greater than 150. Now, this is why I continue to check total cholesterols. Many doctors have stopped checking total cholesterols. They just look at LDL. We should be aware that when your cholesterol drops too much in the advanced elderly population, it's associated with higher mortality, just as an LDL less than 40 has been associated with negative outcomes. I try to keep all of my total cholesterols at least above 120, preferably above 150. And this is just a third study looking at the same thing. Residents had a 10-fold increased risk of dying if they had low cholesterols, particularly low in this case, 89 milligrams per deciliter. The nadir for this group seems a little bit more reasonable, but it's still higher than we're used to, 181 milligrams per deciliter. What I would say about this study is that low cholesterol was associated with all of these negative outcomes: decubitus ulcers, elevated white counts, needing feeding tubes, being bedbound. But in this study with low cholesterol, low albumin, and low hemoglobin, if you had all three of those, the mortality rate for these patients in combination was 84% at 1 year versus 7% if they had none of these. This is just looking at the inflammatory suppression from frailty of 3 biomarkers. And you can know this before any adverse event occurs. Just to bring this to the hospital, low cholesterols after starting with a good cholesterol, or excuse me, these are 2 low cholesterols in a row. Mortality rate was 32%. You can see it was particularly high for heart, liver, and cancers. This is people who start with a normal cholesterol and then drop a cholesterol to less than 120, longer lengths of stay. You can see they would have more complications. They probably had surgery, and there was a slightly, although hard to call that statistically significant, there's only 10 versus 4 deaths. Not enough patients to be sure, but you can see what I'm trying to point out is that when cholesterols drop or they are absolutely low, that is clinically significant and has potent information in advising patients on their outcomes. So I wanted to show you this article because you can use these biomarkers in different ways as well. This is an article looking at nursing home patients' likelihood of surviving a pneumonia. And in this article, they looked at diagnosis, demographics, ADL status, cognitive status, vital signs, things we're used to looking at, medical conditions, catheters, decubitus ulcers, laboratory values, comorbid conditions, and the issues most associated with the probability of dying from your pneumonia were not the ones we think of, O2 sats or respiratory rate. It was complete ADL deficiency, poor renal function, and low cholesterol. So patients who started in the nursing home, who had these things, and they got a pneumonia, they were the ones that were going to die. You can use this information to prognosticate and advise the patient and the family. In fact, when I worked in nursing homes, I haven't done that for over a decade, many of the nursing homes were shocked and thought, what is this guy doing asking about the patient's total cholesterol when I'm calling telling him that he's got a cough and a low-grade fever? And the answer was that I would use this prognostic information to talk to families about what we can expect if we treat the pneumonia or not. I'm going to show you how you use all of this in anticipatory guidance. This is a real patient. This is a patient I inherited in a nursing home, 71-year-old male. He came to me from the hospital. He was there overnight in the ER. I didn't directly get admitted. He had a moderate heart failure and dementia. He had been living in assisted living. He had a tib-fib fracture. And not surprisingly, demented patients come in, they get rehab, but many of them don't go back to their previous level of function. One of the general prognostic tools you can remember is this is national data. 20% of Medicare discharges from the hospital go to the hospital. They all go skilled. 2/3 of those will go home and 1/3 will become custodial. Of custodial patients, about half of them are dead within 6 months and the others live for several years. So using your prognostic skills, this patient was not a terminal patient, but he was unlikely to be able to go home. So as soon as he hits the door, or as soon as you discharge him from the hospital, you can anticipate that he is going to become a long-term custodial patient, which is exactly what happened. Using anticipatory guidance and the skills we've been talking about, he ultimately developed frailty in addition to his other diagnoses. But you can see other prognostic tools. His frailty caused him to become more socially isolated. When I would go to the nursing home, he would be the facility greeter, and then suddenly he would withdraw. That was a warning sign to me. You can look at his weight, which suddenly started to decline, as I've shown you happens in research. You can look at his ADL decline over time, all giving prognostic information. You can see that his albumin finally dropped to 3.4. And you can see, using LDL, you can use that as well as total cholesterol, that his LDL dropped even though his medications hadn't changed. His hemoglobin was dropping. His pro-BNP was rising because he did have heart failure. And his creatinine was dropping because he was losing muscle mass. And using those professional skills, anticipatory guidance, and knowing his frailty and why this was happening, when all of those started to occur at the same time, I admitted him to hospice. Now, technically, if you use concrete criteria, he doesn't qualify for hospice. But if you can define why this patient is terminal, the Medicare LCD criteria are a guideline. Because it's a guideline, I could admit this patient to hospice, just to prove me right, he developed a pressure ulcer on both of his heels, which is particularly prognostically poor. He developed delirium, he developed a pneumonia, and he died 4 months later. That's called anticipatory guidance. And so using those anticipatory skills, I talked to the staff because they get close to these patients, and I talked to the family and I said, what do you want to do? And we all agreed it was in his best interest just to keep him comfortable at the facility, and he died peacefully in the nursing home. So that's the conclusion to this presentation. I know it's a lot of information, but this is the way you can use frailty and understand it better. Unfortunately, it's vastly under-recognized. It's an independent diagnosis. It is progressive but treatable, and it has a predictable course with significant prognostic consequences, and I'm hoping that we covered all of this information. So thank you very much.